same as Jaipur. I am presenting a case of 44-year-old lady who is a resident of Haryana, housewife by occupation, who presented with chief complaints of history of laparoscopic cholecystectomy 4 months back, with complaints of passage of yellowish green fluid from the abdominal tube for around 3.5 months. In history of present illness, she was apparently all right 4 months back when she was evaluated for right upper quadrant abdominal pain for a duration of 2 weeks and was diagnosed to have gallstone on evaluation. At that time, she had no complaints of jaundice, vomiting, fever, or anorexia or weight loss. She underwent laparoscopic cholecystectomy, which was performed electively, which lasted for around 90 minutes. No transfusion of any blood products was done intraoperatively. No dent was placed in the abdominal cavity. She was allowed orally on postoperative day 1. She was discharged on postoperative day 2. And the biopsy report, as informed by the attendants, was normal. Post-discharge, she presented to other hospital after 4 days of discharge, that is on postoperative day 6, with complaints of dull aching, abdominal pain for 2 days, 2 to 3 episodes of gastric content vomiting for 2 days, complaints of passing high-colored urine and yellowish discoloration of sclera, which lasted for 2 days. She was passing yellow-colored stools. There was no history of fever, clay-colored stools, or itching over the body. She was admitted and evaluated by MRI scan. A USG-guided aspiration of yellowish-green fluid was done from the abdominal cavity of around 200 ml. And some endoscopic procedure was performed to place a stent. Post improvement of her symptom, that is resolution of pain and jaundice, she was discharged after 1 week on normal diet. Post discharge, she again presented to same hospital after 3 days, that is on post-operative day 16, with complaints of gradually progressive abdominal distension, dull aching abdominal pain, and 2 episodes of fever. She was readmitted, evaluated again with an MRI scan. Endoscopic procedure was repeated and a stent replacement was done. She underwent USG guided fluid aspiration, which was greenish yellow in color, from the abdominal cavity in that admission 2 times with aspiration of around 500 ml of fluid each time. She was discharged after 4 days on normal diet. After discharge, since persistent after 2 days with the tube output of around 200 to 300 ml per day. And now she has presented with complaints of persistent drainage of yellowish green fluid from the abdominal tube for last 3.5 months. Complaints of weight loss around 3 kg in last 3 months. There is no complaint of yellowish discoloration of sclera, passage of high colored urine, pruritus, clay colored stools, fever, hematemesis of or melena. Lastly, she has no history of any comorbidities. There is history of laparoscopic cholecystectomy and endoscopic procedure as mentioned in the history above. The family history was not significant. In personal history, she don't have any addiction. She has normal sleep pattern and normal bladder bowel habits. In order to summarize,
others, please mute your microphone. Except for the presenter, others, please mute your microphone. Yeah.
To summarize, a 44-year-old lady with history of laparoscopic cholecystectomy 4 months back, with multiple previous admission, with history of USG guided greenish yellow fluid aspiration from the abdominal cavity 3 times, and an endoscopic intervention twice, with persistent passage of around persistent drainage of around 150 ml of yellowish green fluid from the abdominal drain tube for last 3.5 months.
Okay. So, what is your impression from the history?
So from the history, as she is passing yellowish colored stool and there is no history of any jaundice, so I suspect there is no complete injury to the complete circumferential injury to the bile duct. She is a case of bile duct injury, most likely could be a sectoral duct injury or a partial injury to the extrahepatic biliary tree.
Mm. Okay. For the time being, probably we should not comment on the nature of the injury, as unless you confirm the color of stool as colic by your examination or inspection of the stool, any photograph of the stool. Even acolic stool
Okay, sir.
patients say as yellow. So we should not go for
Sure.
that. Second is she is having persistent, it is more than 14 weeks now, 3.5 months. So 3.5 months, uh,
Yes, sir.
if the patient uh, had a bile duct injury otherwise also, it should have healed and formed a stricture by now, usually
Yes,
by
sir.
6 to 8 weeks. But this is more than 6 to 8 weeks time, and still the tube is persistent. Output is there. That is something unusual in this patient. Uh,
Yes.
okay, let's go with the examination. Then we'll see the records.
Okay. Coming on to general examination, at the time of examination, she was conscious, cooperative, sitting comfortably in bed. She was moderately built and nourished. Her BMI was around 20.31 kg per meter square. She had no pallor, icterus, edema, or any signs of dehydration. She was afebrile. Her pulse rate was around 85 per minute. Respiratory rate with a respiratory rate of 20 per minute and BP of 130 by 70 mm of mercury. On abdominal examination, on inspection, the previous laparoscopic surgery healed scar was noted. A PCD was noted in the right hypochondriac region. The abdomen was flat with centrally placed umbilicus. There were no signs of dilated veins, visible pulsations, or any peristalsis. All quadrants were moving corresponding with respiration. There was no evidence of any cuff impulse at hernial orifices and no renal angle fullness was noted. On palpation, the abdomen was soft, non-tender. There was no evidence of any organomegaly. No palpable cuff impulse was noted at any hernial orifice or previous port sites. And there was no renal angle tenderness. On percussion, the liver dullness starts at fifth intercostal space and the liver span was around 13 centimeter in mid-clavicular line. The abdomen was tympanic and no free fluid was noted. On auscultation, normal bowel sounds were heard. On digital rectal examination, the no abnormal findings were noted. The gloved finger was fecal staining. Rest of the respiratory system, cardiovascular system, and central nervous system examination was not was significant. Not any significant derangement were noted. So, in order to summarize, a 44-year-old lady with history of laparoscopic cholecystectomy 4 months back, with multiple previous admission, with history of USG guided yellowish green fluid aspiration from the abdominal cavity, and endoscopic intervention twice in the past, with persistent drainage of around 150 ml of yellowish green fluid through the abdominal drain tube, with no icterus and gloved finger showing fecal staining. It is a case of bile duct injury with controlled external biliary fistula. Status post laparoscopic cholecystectomy in 16th week with no clinical evidence of cholangitis. Sir.
I would not comment on controlled external biliary fistula without any imaging. You have just done history and examination. So controlled
Okay.
external biliary fistula should be commented after an imaging rules out any other collection. There may still be a bilioma at the hilum. We don't know yet. Okay.
Okay, sir.
And you have to mention the fecal staining, whether it is colic stool or ecolic stool. Just mentioning fecal staining
Okay.
on digital rectal examination is not enough. What was in this patient? It was colic or ecolic?
It was colic stool, sir.
Colic. So rather than fecal staining, mentioning as colic stool present is more relevant for this case.
Oh, okay, sir.
And summary, can you make it shorter? History and examination, can you make it more like succinct in a single sentence? A 44-year-old
Uh,
lady with laparoscopic cholecystectomy 4 months back had multiple intra-abdominal collections which were aspirated twice, and then PCD placed, and PCD draining persistent 150 ml of. Now you don't have to say yellowish green. You would have examined, so it it is bile. In the
yes,
examination PCD tube, you would have seen the nature of the fluid. It is probably bile. So we're draining uh, about 150 ml bile per day persistently for the last 3.5 months, and on examination having no signs of sepsis or icterus and colic stool on rectal examination.
okay, sir.
So this is also a patient who is more than 12 weeks or uh, of external biliary fistula. You should look for signs of fat soluble vitamin deficiencies in the
Okay,
examination. It is a part of special general examination. So you have to probably check for bite out spots. You have to ask history of night blindness.
okay,
So you have to check for fat soluble vitamin deficiencies also. EC
okay,
fatigability and muscle pains, they are signs of vitamin D deficiency. Bite out spots, night blindness, vitamin A deficiency. Any bleeding tendency, maybe vitamin K deficiency. So these are some extra additional points you have to see because it is 16 weeks she is having bile loss.
yes, sir.
Okay. Okay. What do you want to do now? You are sitting in the OPD. This patient is sitting in front of you. What is your next plan of action? You have any
Uh,
differential diagnosis or only one diagnosis?
Sir, at present, my differential diagnosis is bile duct injury, which is uh, either partial injury to CBD or CHD, or I would keep sectoral injury above a partial CBD injury because she is almost having an ERCP stent in situ for around 3 months, and despite of that, the at the initial time of discharge, bile out her drain tube output was around 300 ml per day, and she is persistently having more than 150 ml of bile output through the PCD. So most of the patients with a partial CBD or CHD injury, the ideally the drain tube output should have decreased, and if the patient is forming a stricture, and she would have developed at no, if since she is having a drain tube is ER stent in situ, the she won't have developed a jaundice, but her PCD output should have decreased by now, especially
Yeah.
after 3 months.
Yeah, you have a point. Sectoral duct injury, where the sector has been excluded from the system. So
Yes, sir.
that case, ERCP probably will not have any effect on the um, bile output. And
Bile
if
drainage.
internal fistulization doesn't happen, then probably the drain output is going to be persistent. And
Yes.
her amount of bile, normally it is considered 500 to 700 ml of bile is produced per day, depending on the hydration status of the patient and the liver status. So this patient is having less than that, about 150 to 200 ml per day. So
Yes, sir.
probably the whole bile production of the liver is not coming in the drain. Probably some part is going into the intestine, causing colic
Yes.
stool, and some part is coming out. And partial injury, if the ERCP stent has crossed the site of injury, probably the lateral leak should have stopped.
Yes, sir.
It has not stopped. Any other DD? Sectoral injury is one. Partial injury probably is unlikely. Any other DD?
Mm, no, at the moment, sir, I am having these two differentials only.
One thing you should always remember in unhealed bile duct fistula, persistent fistula is also CHGB. So if the
Okay.
you have not checked the biopsy report yourself, you are believing the words of the patient that it is normal. So if there is a CAGB and some malignant cells in the bile has been spilled at the hilum, probably it is not going to let the bile duct injury site heal. So that is another thing you have to remember, because we live in a place, North India, which is a high prevalence area for CAGP. So this should always be kept in the back of the mind.
Yes. Sure.
Okay. So what do you want to do next?
So first of all, I would like to review her previous records personally, and post that I would like to do a imaging investigation mostly and MRCP, as her previous MRCP was performed around 3 months back, and the MRCP will help me distinguish, characterize the type of injury, as her previous MRI scans were done with a fluid in with the peritoneal fluid in situ, and the aspirations were done post MRI scans. So it is possible that the previous MRI scan findings might be deranged because of the fluid present in the peritoneal cavity.
At the time of acute injury, probably MR should be deferred or CT should be preferred, because MR is going to be less useful. You are not going to do any repair, and MR may help in establishing whether there is continuity of the biliary tree, biliary continuity is still there, or biliary discontinuity is there. But regarding the type of the injury, because the system is undilated and there is overlapping peritoneal fluid over the liver hilum, MR, you should understand, MRCP doesn't study the soft tissue. It studies the biliary fluid column, which
Yes.
shows as static fluid column in the MR. So, in an undilated duct, when there is another static fluid outside the bile duct, then both the fluid is going to overlap and your information is going to be less.
Yes.
So that is one of the points to remember. In the acute setting, your target is not to find out the type of injury. Your target is to make the patient sepsis free and make the intra-abdominal collection drain and make it a controlled fistula. That is the target. So CT scan is a superior investigation and a faster investigation for looking for intra-abdominal collection. And it can also help the intervention radiologist to look for the root of the PCD placement.
Yes.
And another advantage of CT scan is you can add an arterial phase and you can do the check for any associated vasculobiliary injuries, any portal vein injury or any right hepatic artery injury, any pseudoaneurysm. So if these are there, you can prophylactically embolize them so that you can prevent a torrential sudden bleed, which may destabilize the patient or it may be life-threatening for the patient. Your aim in the acute setting is to salvage the life of the patient and then make the patient sepsis free. Once the patient is sepsis free and in a controlled biliary fistula, then you can do the further workup after giving a period of conservative management of maybe 6 weeks for the fistula to heal, and then you can do studies to evaluate the anatomy of the bile duct injury. This is where MRCP comes into the picture.
Yes.
Okay. Do we have the previous records?
Yes, sir. I am having a few records. Her preoperative investigations, the abdomen report was suggesting 2 to 3 gallstones. No evidence of wall thickening. The CPD was normal. The pancreas was normal. Her CBC and LFT were grossly normal. It was not deranged, and the operative notes were not available with the patient. On this is her post-operative day 5. The time she presented first time with complaints of jaundice and abdominal pain. This is the CBC report, which is showing WBC counts of around 18,500, and her total bilirubin was raised to 3.32 with a direct bilirubin of 2.01, and her OTPT were normal. Her alkaline phosphatase levels were also normal. So this is why I didn't.
What do you understand? The CBC and LFT. What do you think is going on?
Sir, as her WBC counts are raised, and on LFT, there is no evidence of uh, significantly derangement of SGOT-PT. So I think it is most probably because of the fluid collection within the abdominal cavity and not specifically because of cholangitis. Her total bilirubin is raised, but alkaline phosphatase levels are normal. So
Why the total
I
bilirubin is raised?
personally,
Why do you think that the
yes, sir.
total bilirubin raised?
Sir, one probable cause was that there might be slippage of a stone during cholecystectomy into the CBD, but before stent attempt also she was passing colic stools as per the patient, and in the investigation we can see there is no rise in the serum alkaline phosphatase levels. So it could be probably because the collection, biliary collection within the abdominal cavity, and slight amount of rise in bilirubin because of the absorption from the peritoneum.
Yes, correct. So it looks unlikely to be a CBD stone because alkaline phosphatase and OTPT are normal, and
Yes,
counts are raised because of the intra-abdominal bilioma that is causing sepsis. And if you see in that, the direct bilirubin is raised more than the indirect. So the leaking bile in the bile duct is a conjugated bile. It
yes,
has conjugated bilirubin. So
yes,
that conjugated bilirubin is absorbed through the peritoneal surface into the systemic circulation. So there is rise in. So usually you will find if patient is having bilioma, you will find about 3 to 5 the value of the total bilirubin, of which more than 50% will be direct. So that doesn't mean that there is a biliary obstruction. It is because of the reabsorption from the peritoneal cavity. Yeah.
yes.
So you don't have operative notes, you don't have biopsy in this. So if uh, you get the number of the operating surgeon, what will you
Yes,
ask him in this scenario? At that time, in the post-op day 5, when patient
yes, sir.
present, let's assume that presented to your center with this CBC LFT, then what will you ask the operating surgeon?
Sir, firstly, I would like to ask him about her preoperative status, like she was icteric or not, whether she had similar episodes of such complaints in the past, whether the pain was radiating to back at that time, her uh, her other her detailed LFT report, and I would like to ask intraoperative findings of the patient, like whether there were any adhesions, like omentocystic adhesions were present or
Before intraoperative, preoperative, in addition to what you asked, anything else you want to ask? Preoperative, before uh, the current presentation, if she has previous history of similar complaints, what does it signify?
uh, it will signify that she is having recurrent colicky pain. So there could be possibility that she might have chronic cholecystitis at
Yes,
the time, and such gallbladders are usually atrophic and small size, and which causes difficulty at the time of dissection at the calyx.
that's correct. So if there is multiple attacks of acute cholecystitis in the past, or there is a very long history of many years, then that may signify a contracted GB, chronic cholecystitis, or a possible MIRZ.
Yes,
So that can give a clue whether this cholecystectomy was a difficult cholecystectomy. Second, if the pain was radiating to the back, that can signify probably patient has acute pancreatitis before this.
yes,
So acute pancreatitis may lead to more adhesions and may be leading to difficult. Another you have to ask is any history of jaundice prior to this cholecystectomy. And if there is a jaundice which improved by itself but not completely resolved, that may mean a distal CBD stone which is impacted and got disimpacted. And
yes,
then that can be a high risk factor for cystic stump blowout in the post-op. So these are some you have to ask. And any history of anorexia and weight loss in
yes,
patient, especially who is having a prolonged history, and any recent change in the character of the pain. That may
pain.
signify malignant transformation in pre-existing cholecystitis or cholelithiasis background gallbladder. and then maybe a missed gallbladder cancer by the preoperative investigation and intraop, it can lead to more difficult dissection or bile duct injury.
Yes.
Okay. Then in the ultrasound, what do you want to see? Any specific you want to see in the pre-op? You are given the
For
ultrasound.
ultrasound,
Anything
firstly, I would
specific you
like to
want to look
see
at?
if there were, considering the gallbladder point of view, I would like to see if there was any thickening of the gallbladder wall, whether there was any stone impacted at the GB neck,
Yes.
whether there was any peri-gallbladder collection, then if there were any IHBR dilatation or any proximal CVT dilatation,
Yeah.
and the whether status of the pancreas I would like to assess, sir, whether there were any fat standing surrounding the pancreas or bulky pancreas.
Pancreas ultrasound is not a very good investigation to comment on the pancreas. Many times it's a retroperitoneal organ and not well seen in the ultrasound due to poor window. But all other things you told regarding the gallbladder and bile duct are very correct and should be seen. What is the gallbladder wall thickness you consider as a cutoff for thick wall GB?
So gallbladder wall thickness of around more than 4 to 5 mm will consider as it is inflammation.
Yeah, 4 mm. 4 mm is the correct answer. And have you seen in the ultrasound report something called WES? They write in the gallbladder showing WES sign. What is that? Have you seen it sometime?
Yes, sir. At the moment, sir, I am not.
Okay. WES is wall echo shadow sign. So it means that the uh, the gallbladder is packed with stones and there is no bile. So that may signify that it's a contracted GB or chronic cholecystitis. So if WES sign is also there in the ultrasound report preoperative, that can give a clue that it may be a difficult intraop dissection.
Okay.
Okay. Then intraoperative, what do you want to ask to the surgeon?
Sir, I would like to ask whether there were any adhesions with the gallbladder, like omentocystic adhesions or cholocystic adhesions or any duodenocystic adhesions were present. The status of the gallbladder, like whether it was tensely distended with a impacted stone at the GP neck, the consistency of gallbladder wall, whether it was a thinned out gallbladder wall or any gangrenous changes were noted in the gallbladder, whether there were any difficulty in achieving the critical view of safety, whether it was achieved intraoperatively or not, whether any uh, abnormality in the biliary system, abnormal biliary duct drainage was noted. Any
Any
vascular
low
injury?
inserting duct at the Callet's triangle?
Yes, sir.
Uh,
Any intraoperative blood loss that was uh, controlled with by applying a clip or using electrocautery or not? And
okay, so two types of gallbladder are present in intraop, and both bile duct injury can happen. One is the typical so-called easy blue gallbladder. Okay, so a patient who is having symptomatic cholelithiasis, there is minimal omental adhesions, and once adhesions are taken down, you see a thin-walled blue gallbladder. That is usually gallbladder which most of the trainees start doing lab chole. So in this, the gallbladder holding is easy, and still the bile duct injury can happen if there is a bad anatomy, like there is a uh, low inserting aberrant bile duct. Either it's inserting in the CHD crossing the calyx, or it is inserting into the cystic duct, or it is sometimes if it can insert into the gallbladder itself, or there can be a duct of Luschka which is entering the gallbladder bed. So these are some of the scenarios where there can be injury and bile duct by injury. Otherwise, if the surgeon is not very careful and does excessive traction on the left hand, So that can lead to tenting of the CBD, and the CBD being thin walled, he can misunderstand the anatomy, and then the lower CBD may be thought of as the cystic duct, and the classical injury can happen where a segment of CBD is excised and CBD is considered as cystic duct and RHA is considered as cystic artery. So this is one type. Then
Yes.
second type is the non-blue gallbladder, where you have the acute cholecystitis, you have the empyema gallbladder, you have the gangrenous gallbladder, then thick-walled chronic cholecystitis gallbladder, Mirizi syndrome gallbladder, and CAGB thick-walled gallbladder, where there may be doubtful CAGB. So all of this, probably the gallbladder is difficult to hold. You are
Yes.
either doing decompression to hold the gallbladder, or gallbladder difficult to hold. The adhesions are more, colonic and duodenal adhesions are probably present more in these type of cases. So you need
Yes.
more experience to understand the anatomy and do a careful cholecystectomy in this type of cases. If you have less experience or you are overconfident to and persist with demonstrating critical view of safety in this type of gallbladders, then probably you can injure the cystic duct. You can injure the CBD. So most
Yes.
of these, if it is very difficult to demonstrate the critical view, probably you should give up demonstrating critical view, and then you should go for other markers like the sulcus of Rouvier, the hilum, hilar plate, and then you should dissect above this and maybe do a subtotal cholecystectomy, or you have to be more careful in exposing the hilum and trying to dissect and demonstrate the critical view in these type of gallbladders. So you have to ask the surgeon whether it was a blue or non-blue gallbladder
Okay.
first,
Okay.
and then if it is a blue, well, then he had any aberrant duct, anything, and if it is non-blue, then how did he demonstrate the critical view? So if it is a non-blue difficult gallbladder and he says I successfully demonstrated the critical view, that means probably it is the CBD. It is not the, because post-op bile has come. If bile has not come, then we can accept that it is the correct duct he has clipped. So that is one. Then, as you rightly said, any bleeding. Usually, the cystic artery is seen and clipped, and you should not have any excessive bleeding at the if you are in the calyx level. But if you go into the liver hilum, you are behind the CBD, where the RHA comes and the portal vein is exposed. So you can have increased bleeding, especially when you're using monopolar cautery hook or Maryland to dissect. And
Yes.
then what you do with the to control the bleed, whether, so if there is excessive bleed, most of the people they panic a bit, they take sutures or they put clips blindly to control the bleed, and they apply cautery. All of this are wrong. If any of this is done, there is more chance that you may apply clip on the bile duct,
Right.
or you may suture the bile duct. So best is just to put a gauze and wait, apply pressure 5 to 10 minutes, and just wait. Most of the bleeding stops because the vessel goes in spasm, or with the pressure there is, if the patient is not having any coagulopathy, the clots form and the bleeding stops.
Yes.
So if it doesn't stop, then you have to probably call a more experienced surgeon or your unit head to assess, and then probably he should scrub and do the hemostasis. If you are not having any other senior surgeon around, then probably you should consider converting to open and
Open.
properly assess from where is the bleeding, and then take appropriate measures to control the bleed. And another important question you have to ask intraop is, did you see bile?
Bile.
Did you see bile in the from the beginning to the end of the surgery? If you see bile, where did you see the bile? Was it from the liver hilum? Was it from the GB bed? Was it from the duodenum? So, did you see bile? And what was the color of the bile? If it is CBD bile, usually it is golden yellow. If
Yes.
it is GB, it can be green or it can be pus, it can be anything. Duodenum, it is clear green fluid, or it can be yellow. So if the person has seen bile intraop, then probably you should be very careful, and probably you should always put a drain. This surgeon has not put a drain, so if you see bile, you should probably put a drain. And you
Right.
have to ask, how did you tackle the bile? Did you just put a drain? Did you put a clip over the side to control the bile? Did you take sutures? You have to ask that also. And any intraoperative transfusions were given? Was the surgery prolonged? A normal lab chole or difficult lab chole also should be over by 2 to 2.5 hours. So if a surgery is prolonged more than 4 hours, probably there is something wrong. And if the
Yes.
surgeon has converted to open, then you have to ask why you have converted to open and what did you do in open. Did you try, identify bilateral injury? Did you try to suture it or repair it end to end? So any attempt at repair probably is going to make the level of injury worse. If the
Yes.
transaction was 2 centimeter below the hilum, probably if you take bite, you're going to take bite 5 at least thickness. So you're going to, where you're taking the bite, that site is going to be the site of stricture, not the site of transaction. So your stricture is going to be at a higher level. You're going to convert a
Yeah.
type 1 injury, E1 injury into E2 or E3. And when you take bite, probably you are panicked. You may take bite along with the artery, so you may have a risk of pseudoaneurysm formation or converting a pure biliary injury into biliovascular injury. So suturing and repairing on table is probably should be avoided. You just have to put drain. I will advise probably we should put two drains. Mostly the Morrison's pouch drain is enough, but we have seen patients where Morrison's pouch drain doesn't work and the bile also goes below the left lobe towards the left subdiaphragmatic space sometimes.
Okay.
So probably two drains, one drain from the left anterior to the hilum and one drain from the right posterior to the hilum. That should be the, and then you have to refer the patient to a higher center. That should be
Yes.
the thing. And always we have to send the gallbladder to biopsy and we have to follow the biopsy whether CGB is there or not.
Yes.
Okay. Then in the post-op, what do you want to check? After coli, post-op, what happened? What do you want to ask the surgeon?
Post-operatively, sir, I would like to ask him whether the patient had any sort of tachycardia in the post-op, any hemodynamic instability, or any complaints of fever, whether she had any complaints of abdominal pain, and post starting her orally, whether she was able to tolerate orally or there she had complaints of vomiting post-operatively, and
Yeah.
whether if she had passed stools in post-operative period, what was the nature of stools, whether they were colic stools or colic stools.
So VK Kapoor sir says in the post-op, anything out of the normal expected post-operative course, you should not discharge the patient. So what is the normal expected post-operative course? On the day zero, beginning of the surgery, patient should be comfortable and except for epigastric port size should not have any other pain.
Yes.
And on day one, patient should be able to tolerate a soft diet and patient should not have any discomfort. Patient should
Yes.
be looking as though she is good to go home. If there's anything abnormal, if there is tachycardia, if the patient is having abdominal distension, patient is having vomiting, she is having fever, she is having more pain than expected, other than epigastric port site, other areas of the abdomen, she is having pain. Anything out of the normal, you should hold the discharge, observe the patient for 1 or 2 more days, get a repeat CBC, LFT, and ultrasound abdomen. In ultrasound abdomen, you have to look for any intra-abdominal collection and IHBRD and CBC LFT. You have to see whether there is any increased bilirubin, any increased counts. Some increased counts is normal due to the stress of surgery, but she is increased. And then if it is absolutely fine, then okay. If there is something wrong, then probably you should evaluate further with a CT or something, not discharge the patient. And other things, if it is
Yes.
outside center, you should ask is whether the patient was shifted to the ICU post-op, whether the patient received any blood transfusion post-op. If a drain was placed intra-op, what was the nature of the drain output in the immediate post-op? And sometimes the patients are discharged after 4 days with the drain in situ. Usually you remove the drain and then you discharge the patient. So you have to ask
Yes.
why the drain patient was discharged with the drain. Was the nature bile or was it pus? Why patient was discharged with the drain? So these are some of the questions you should ask the operating surgeon. Many times, the operating surgeon may not document these things in the hard
Operating note.
copy of the discharge summary OT notes for fear of medical ramifications. But if you talk over telephone, the operating surgeon usually will give you all the information, because even the operating surgeon wants the patient to do well. Like you want the patient to do
Yes, sir.
well, he also wants the patient to do well. He will give you all this information, thinking it may help you in managing the patient better. So you should
Sure, sir.
always collect the phone number and make an attempt, sincere attempt to talk to the operating surgeon, as so much more information you will get, which will help in managing the bile duct injury.
Sure, sir.
Okay. Let's go with the other investigations, and then we'll see what is the current management. At the immediate MRCP,
She was this is the first MRCP she underwent on post-operative day 7 before fluid from the abdominal cavity, which was suggestive of the gallbladder was not visualized post-operative status. There were evidence of mild perihepatic fat standing with free fluid in the gallbladder fossa at the post-op site, perihepatic space, perisplenic space, hepatic hilum, and in Morrison's pouch.
let's not read it
Body,
verbatim. We are having less time. So there is collection and there is discontinuity in the right hepatic duct. So the
yes, sir,
summary of the findings is this. And in the ERCP, they have found leak at the mid CBD level,
mid
and
CBD level, sir.
they
They
have
have
placed
put a
the stent.
7 French drain plastic stent in the CBD.
Okay.
And post that, she had improvement in her symptoms. She was discharged. And again, she presented after 2 to 3 days of discharge on POD 16. With the initial screening, a USG abdomen revealed mild to moderate ascites. The fluid was persistent in the abdominal cavity. They did a repeat MRCP scan, and
Which showed
in this scan, they could not.
it showed again a collection, but
Yes,
not much information about the bile duct.
bile duct injury.
Because
The
the
site of
collection
bile
was
duct injury could not be assessed
right.
from this scan.
The
And post
collection
this
was
scan,
bigger, so probably it was overlapping the hilum.
yes, sir.
Yeah.
And post this scan, she underwent 2 times USG guided aspiration, one time around 400 ml and second time 600 ml. And post that scan, they have repeated an ERCP and they exchanged the previous 7 French plastic stent with a 10 French plastic stent.
Mm-hmm. So,
And post
uh, yeah, you they have placed a
and
PCD.
yes, sir. And no, sir. This was the PCD was not placed in that admission.
That
She was
it
discharged
was
after 2 time aspiration, and later, in view of persistent complaints, she presented to a tertiary center where a USG guided PCD was inserted in the abdominal bilioma, and statly she drained around 1200 ml of bile from the PCD. And post that, she had a output of around 300 to 400 ml per day. She was discharged on normal diet, and now she has presented, and her screening USG was done on the OPD basis uh, in the 16th week, and this 16th week examination was suggestive of a 100 cc collection in left subhepatic space, where the POS PCD was slightly displaced. The CBD was not dilated. There were no left IHBRD, but a mild central IHBR dilatation was noted in the right lobe with dilatation of RHD around 7 to 8 mm, more probably a right hepatic duct stricture.
So we just discussed, right? Sometimes the bile goes into the left side.
Yes, sir.
You can see in this 100 ml collection in the left subhepatic space. And that's why before seeing any imaging, don't commit to controlled external biliary fistula in your diagnosis. So
Yes.
you have to be correct. And
Yes.
there is probably some continuity. The ERCP is entering into the stent is probably entering into the left duct. They have not provided cholangiogram images clearly, but
Yes.
there is appearing to be some leak at the junction of the right duct to the mid CBD. We don't know whether there is any low inserting right duct or any aberrant right duct, or it is the classical right duct with side injury.
Yes.
Then what do you want to do now?
These are her present blood investigations, sir. The WBC counts are within normal limits. Her OTPT are slightly deranged to 102 and 147. Her total bilirubin counts are normal. Her alkaline phosphatase and GGT is raised significantly to 1039 and 1294. Her albumin levels are 3.4, and there is no any dyselectrolytemia as per the investigation.
Okay.
So moving forward, I would like to get a repeat MRI scan for this patient now in order to assess whether the stricture has formed and the characterize the stricture according to that.
Before
And
MR, why don't you put another PCD into that left subhepatic collection?
yes,
You have a 100 ml collection. So once you put a PCD and get that out, then your MR is going to be more accurate probably.
accurate.
Okay.
Yes.
Then anything else has been done, or
No, sir, no. The
is
further
present now on
investigations
the?
are have it.
Okay. Okay. So what should be your target in the acute setting of bile duct injury?
Sir, in the acute setting, my first target will be to control the sepsis, to convert acute bile duct injury into a controlled fistula by
Yes.
inserting a USG guided or CT guided PCD into the collection. And post that, I would like to control if we see if there are any signs of sepsis, and if the patient requires accordingly broad spectrum antibiotics coverage or not.
Rather than broad spectrum antibiotics, send the bile for the culture.
Yes, sir.
Whatever PCD bile you are getting, send it for culture. Broad spectrum antibiotic is okay for the 3-4 days, initial 3-4 days.
Yes,
Once you
initial.
get the culture, usually the bile, the organism is GNB, and nowadays most of the GNB in tertiary centers are carbapenem resistant.
Yes,
So with E. coli or Klebsiella or Pseudomonas. So it is better to get the culture sensitivity, and if it is carbapenem resistant, then you have evidence to start high antibiotics. Empirically, probably you will not start colistin or polymyxin in every case, but with
no,
evidence you can start. And the organism usually is the same. The first bile culture, whichever organism comes, till the end of that patient's clinical course, that same organism stays in the bile. So you can know that in the future, any intervention, any ERCP or PCD, before that you can cover the patient with that sensitive antibiotic, and before the surgery you can cover the patient with the same antibiotic.
yes,
That is one. Then second, you should also rule out vascular injury in the immediate post bile duct injury. So one CT should be done at any point before the definitive management. In this
antibiotics.
patient, always MR has been done. So one CT should be done to check the portal vein and the right hepatic artery. Because if there is any coexisting vascular injury, the outcomes of your uh, definitive repair are going to be inferior compared to a patient who doesn't have vascular injury. So you should know
Yes,
the prognosis, and you should also have the information to prognosticate the patient. So such patients probably you can keep on a close follow-up. There may be atrophy,
yes,
hypertrophy in drop, so it may be a more difficult surgery. So you can be prepared surgically also, and you can prognosticate the patient and keep on closer follow-up or longer follow-up.
yes,
The LFT and ultrasound. That is one. And nutrition, you should also give weightage to the nutrition.
yes, sir.
Please switch off the mic. Please mute your audio. So after the patient is out of sepsis, you have to focus on the nutrition. You have to give the
Yes, sir.
patient high protein, high calorie diet along with fat soluble vitamin supplementation. And if this patient is having folic the fat soluble vitamin is given by oral route. If a patient is having a complete transaction and there is ecolic stool, probably then you have to give intravenous vitamin K and intramuscular vitamin D and vitamin A. There are depot preparations. Before giving them intramuscular, you have to ensure that patient is not in coagulopathy.
Yes,
First, give IV vitamin K. Confirm that the INR is normal, then you give intramuscular. Otherwise, the patient is going to form a large hematoma in terms of
Hematoma.
blood. And in this patient, after 3.5 months, still she's having a persistent external biliary fistula and a persistent biliary collection.
Yes, sir.
So, other than the previous record, as I told earlier, you have to check for the biopsy whether and confirm there is no malignancy. And probably you should try to make the hilum dry before you attempt the definitive repair. So,
Yes.
one to make the PCD for the left subhepatic collection that will drain that and make the uh, hilum and the peritoneal cavity dry. And for the this right side PCD output, there are two schools of thought. One school of thought, they will attempt a PTBD to divert the bile away from the hilum so that the hilum heals, and then you can remove this drain and attempt a HJ. There are pros and
Yes.
cons of this approach. The pros is your hilum is dry at the time of surgery, so the inflammation of HJ healing will be less and less chance of stricture. But the cons is PTBD itself is difficult in a scenario where there is no IHBRD. In this patient,
HBRD.
because there is no jaundice, no IHBRD is there, so PTBD will be difficult, and there is chance of maybe the IR person will deny, will refuse to attempt PTBD, or if they take the attempt, there may be injury to the portal vein in the right side. So it is the risk of this approach. And
Yes.
the other approach, you don't do PTBD to do bile diversion. You can just, if the patient is nutritionally fine, you have done a CT, there is no vascular injury, and you have done MR, you know the anatomy, then you can go in and attempt the repair. But the hilum is going to be wet. Although it will help in identifying the bile duct intra-op, the wet hilum has a higher chance of restricture.
Okay.
So that is a risk of this approach where you go without PTBD. There is a higher chance of restricture compared to a patient having dry hilum. And another good thing which you can do is, other than MRCP, you can do something called a tubogram or fistulogram.
Yes.
So many times you get very beautiful images of that. And this is especially useful in patients with undilated bile duct. MRCP, the sensitivity of MRCP goes down when the bile duct is undilated. When it is dilated, MRCP is very good.
Hmm.
Uh, but if the IHBRD is not there, like in this patient is having no jaundice, in the ultrasound there is no IHBR dilatation. So in this patient, MR may reveal the anatomy well, or sometimes MR may not be very clear. So if you do a
Yes.
tubogram pre-op, you will get more clarity on the anatomy, and it will be more helpful intra-op. You can
Okay.
take the example of the LDLT scenario. When we do LDLT, the donor is having a undilated bile duct. So even though
Yes, sir.
we do MRCP in every case, intra-op before doing anything major, we always do a cholangiogram also,
Okay.
because the cholangiogram is always superior to the MRCP in showing the biliary anatomy, and it improves the donor safety. So similarly, a tubogram may be done. It is very cheap and easy
Preoperatively.
investigation. Uh, so that is another thing. And regarding HJ, hepaticojejunostomy, we are nearing the end of the session. So if you're going to operate this patient, how will you approach this patient? Or what will be your operative strategy? What are the steps you will follow to ensure a good long-term outcome?
Sir, far as the recent USG screening abdomen report, which is morely suggestive of right hepatic duct stricture, and the clinical history of the patient is also uh, suggesting towards a sectoral or right hepatic duct injury as the persistent PCD output. So, in order to identify the right hepatic duct, in order to make the intraoperative identification of right hepatic duct easier, I would prefer to get done a right hepatic duct catheterization in the preoperative settings, which will
So
identify.
you already have a bile leak, right?
Yes, sir.
So as you keep dissecting, at some point and the hilum, bile is going to come. So
Okay.
through that hole, it is going to come from the bile duct only. So you can identify the bile duct. This type of case, you don't need a preoperative cannulation. Preoperative cannulation
Okay.
may be needed for patients who are having a high stricture, like a type 3B, type 4, or type 5 bismuth stricture, where in the MR you can see that the duct ends have gone into the liver hilum. It
Okay.
is retracted proximally, so it's going to be difficult for you to identify. Then you may need cannulation.
Okay.
This IHBRD also, so its cannulation is easy. Preoperative biliary catheterization or cannulation, that's what you call. In this, because there is a bile in the drain, so probably the hilum, there is still bile leak. The hole is not closed. So that is itself is enough for you to identify the bile duct.
Okay.
So your operative strategy, if the patient is nutritionally optimized, like in this, your albumin is 3.4, she is in a
Yes.
sepsis-free window, and
Yes.
it is more than 3 months of the primary surgery. So the overall inflammation in the abdomen is probably settled except for the hilum. So this is a good window to go. So you have to probably do a laparotomy and have a good exposure with
Exposure.
good subcostal
Auntie ko.
retraction, either a Thompson or a
Hoya
good
ko.
self-retaining subcostal retractor.
Eh?
You have to do a first step, parietes to visceral adhesiolysis. Then you have to do suprahepatic adhesiolysis to take the liver will come down, your hilum comes more below, and it's easier for you to see and dissect and do the anastomosis. You can put a couple of pads above the liver. Then you have to do a subhepatic adhesiolysis. Subahepatic adhesiolysis, first is omentum, colon, then duodenum. Careful adhesiolysis without injuring these viscera. And sometimes you may see some internal fistula with the duodenum. So if you find a fistula, then probably you have to loop the fistula, and you can divide it with staple, or you can divide the fistula and take a suture with the interrupted PDS or vicryl.
Okay.
After that, you will probably find out the tip of the PCD and at the hilum, and you follow the PCD, you will find the site
Leaks
of the
that.
bile leak. So once you find the site of the bile leak, then you have to lower the hilar plate. There is something called lowering of the hilar plate, where you expose the anterior surface of the left duct
Yes, sir.
below the segment 4B by opening incising the Glisson's
That's
capsule.
License
You
capsule.
have to do that to expose the
Next
anterior surface of the left duct. Then you have to extend the ductotomy.
On the
Put
left
the right
duct.
angle into the this bile leak side. Extend the ductotomy to the left duct. That is called the Hep quinod extension. The
Yes.
extrahepatic course of left bile duct is about 15 mm to 2 centimeter
Listen to
from the umbilical fissure to the hilum. So utilize this extrahepatic course and extend the ductotomy over the left duct so that your HJ can have a bigger stoma. Because
it.
this
Yes.
having a wet hilum, you need to have as big stoma as possible so that the chance of stricture is less. And
Yes.
right side also, you can extend a bit. And then you have to confirm that your ductotomy is including all the three systems, right anterior, right posterior, and the left.
Posterior and left.
And see if the lower end is open. Because the ERCP is done, sometimes the lower end may be open. And you can remove the stent, the ERCP stent, and lower end, if it is open, you can suture close the lower end. Never try to loop the bile duct because it will be densely adherent to the portal vein. So just close the lower end in continuity and open only the anterior part of the duct, not the posterior part. Then
Okay.
you make a rule limb. You can bring the rule limb either anticolic or retrocolic. Retrocolic has less tension compared to anticolic usually. And then you have to take interrupted sutures, single layer, usually with a PDS or a vicryl. And the caliber of suture should be maybe 3-0 or 4-0, sometimes 5-0 also,
4-0.
depending on the thickness of the bile duct, how much it is cutting through. And nowadays, the evidence for HJ anastomotic stenting is not much. So unless the bile duct is very small, like 3 mm or 4 mm, you don't need to stent. And
Yes.
then place a drain. Ensure that there is no tension. You can do a gauze test at the end of the surgery so that there is no bile leak intra. And if there is any leak, you can take additional reinforcing sutures at the site. But don't take too many reinforcing sutures. If it is interrupted, probably the bile leak is self-limited and it will settle. So maybe
Okay.
one or two reinforced suture is enough. More than that, if the leak persists, just put two drains. That's like the first time I said, one drain from right, one drain from left. Put it, and that's it. That's the best we can do. And with this, the success rate is about 85 to 90% in the long term.
Okay.
Okay.
Selva sir, we need to wind up the session since time is up.
Yeah, we are done. Any doubts? Anything somebody wants to ask, we can discuss. Otherwise, we are done.
Yes. Let's wind up.
Anyone
No,
wants to ask any doubt?
before you close, I will just chip in for a minute. Thank you, Selva. Thank you very much for moderating the session. I was listening and enjoyed the entire presentation, and I am also very happy to note that even in my absence there, all of you are continuing with these sessions, and I hope that you will continue to do these sessions for the JST even after my innings are over. Thank you. Thank you, Anand. Thank you, Selva.
Thank you, sir.